And in the interest of time, we are going to transition to our third speaker, and this will be our final speaker for our resident abstracts. Dr. Anderson, if you want to go ahead and share your slides and come on to camera. Dr. Anderson is joining us from Virginia Mason in Seattle. And I just want to make mention that Dr. Anderson also was presenting 2 posters yesterday, helping out one of her colleagues very impressively. So you have been doing quite a bit. So thank you so much. And just want to mention for the judges, we will be transitioning to a break room right after this talk. All right, your slides look good. I will turn it over to you.
Thank you so much for the introduction. Good morning, everyone. My name is Molly Anderson. I am a second-year internal medicine resident at Virginia Mason Medical Center in Seattle, Washington, and I'm presenting a case entitled Unmasking Blastocystis Diarrhea. I have no disclosures to make this morning. So Blastocystis hominis is a parasitic protozoan. It's transmitted via the fecal-oral route and commonly through the ingestion of contaminated food and water. Our patient is a 37-year-old female with anxiety, intellectual delay, and juvenile seizure disorder. She initially presented to her primary care provider from a summer camp with 5 days of multiple episodes of non-bloody diarrhea. And at home, she had tried loperamide with no relief. CBC and CMP were unremarkable. And she underwent an extensive infectious workup, including Clostridium difficile, Cryptosporidium, Giardia, Campylobacter, Salmonella, Shigella, Vibrio, Yersinia intercalatica, Shiga toxin 1 or 2, Aeromonas, Plesiomonas, norovirus, and human immunodeficiency virus, which were all negative. Of note, she had been recently treated with antibiotics for a urinary tract infection. Unfortunately, she had ongoing diarrhea for 5 more days, which prompted her to present to the ER. There, she was found to have elevated inflammatory markers, including ESR and CRP, and because of the ongoing symptoms and elevated inflammatory markers, they did a CT, abdomen and pelvis, which was negative for acute abnormality. She was discharged home at that point, and several days later, stool, ova, and parasites returned positive for blastocystis. She was prescribed a 10-day course of metronidazole, 500 milligrams TID, with symptom resolution. However, I will note that she did not complete the entirety of her course. So blastocystis diarrhea actually has this widely variable prevalence from 0.5 to 23.1% in industrialized nations. It remains unclear the clinical significance of blastocystis because it actually is a commonly found GI microbe, and it's found in asymptomatic patients as well. Symptoms of blastocystis are non-specific, including watery or loose stools, abdominal pain, nausea, vomiting, weight loss, or flatulence, and sometimes patients can present with skin rashes or hives. Risk factors for blastocystis diarrhea include poor hygiene, contact with contaminated food, water, or animals, or travel to endemic areas. And it's thought that our patient actually contracted blastocystis from coming in contact with lake water and with contaminated animals while at her summer camp. And while this wasn't the case with our patient, blastocystis diarrhea can actually be associated with IBS, chronic kidney disease, urticaria, and inflammatory bowel disease. Diagnosis is done through the use of stool, ova, and parasite testing, and the first-line treatment remains metronidazole, typically a 10-day course, with second-line modalities of TMP-SMX, tinidazole, paramomycin, and nitazoxanide, and most patients will make a full recovery from this. So in conclusion, clinicians should obtain a thorough history, including environmental exposures and recent travel in a patient presenting with diarrhea, and consider blastocystis as a part of the differential diagnosis. And I am happy to take any questions at this time.
Great. Thank you, Dr. Anderson. We will give our audience a little bit of time to come up with questions. But while they're doing so, I'm wondering for you, what was, other than learning about this specific pathogen? Were there any learning points you took from the case?
I think I always come back to anchoring bias. I think, especially with GI symptoms, a lot of the time we can say, oh, this is a younger patient, they have diarrhea. You think of more of like the typical infectious things, but this case kind of proves like, oh, maybe we should be kind of broadening that thought if the diarrhea is not getting better. And we've ruled out some of the more common things, like she had been on antibiotics, so maybe C. diff, but that was negative, or Giardia with contact with lake water and that kind of stuff.
Yeah, I think that's a really important point, and also gathering that really good history. Dr. Horwich is wondering, how long does it usually take for the stool test to come back positive, the parasite stool test, and why then
So I
10
think
days?
it's, yeah, I think it's a little bit variable. I think in this patient, it took like, I think 3 to 5 days to come back with the testing. So they had already gone to their PCP, still had symptoms, and all of that testing kind of trickled back with all of the things that I read through. And then they went to the ER, got discharged, and then the testing came back with their primary care doctor. So it took like almost a week to come back.
All right. I think those are all of our questions. Thank you so much, Dr. Anderson, and for all of
Thank
our
you.
presenters.